Okay, it's 3:05. Let's start. Good afternoon. I'm Dr. Maribeth de los Santos. I'm a cardiologist with subspecialty in vascular medicine and an associate professor in the College of Medicine, UERM. Now, for this afternoon, uh, my topic is on diseases of the aorta and peripheral vascular system. Now, at the end of the lecture, the students are expected to describe the pertinent anatomy of the aorta and the peripheral vessels relative to the lecture on diseases of the aorta and peripheral vascular bed. We'll be able to discuss the common clinical manifestations of diseases of the aorta and peripheral vascular system. And you'll be able to discuss the management of diseases of the aorta and the peripheral vessels. Now let's start with the short anatomy of the aorta. This is the anterior view of the aorta with the ascending portion of the aorta, the aortic arch, the descending thoracic aorta, and below the diaphragm we have the abdominal aorta. All of these are very important when we go to the different diseases of the aorta and the peripheral vascular bed. And this is very important, the arch of the aorta. We all know that the arch of the aorta, we have the brachiocephalic artery, which divides into the right subclavian artery and the right common carotid artery. Also, a branch of the arch of the aorta are the left common carotid artery and the left subclavian artery. This is a lot of bearing when you go to the manifestations of aortic aneurysm and dissection, because most of the symptomatologies of these diseases are related to the structures adjacent to them. For example, if the dissection involves the arch of the aorta, one of the manifestations will be stroke, since it is adjacent to the carotid artery, which supplies the cerebrovascular bed. Or the patient may have hoarseness because of the enlarging arch of the aorta. There may be impingement of the recurrent laryngeal nerve, which will be clinically manifested as hoarseness. All right, let me just describe the different layers of the aorta. So you have the single layer endothelium, the tunica intima, which contains the endothelium, the tunica media, which contains the smooth muscle cells, the thickest layer that is rich in elastic fibers, and this allows the aorta to stretch for dilatation and recoil to constrict for regulation of the blood pressure and blood flow. The tunica adventitia or tunica externa, which is the outermost layer of the aorta. This is composed primarily of connective tissue or collagen and fibroblasts. This layer also contains tiny blood vessels called vasa vasorum and nerves. And the main function is to to anchor the aorta to surrounding structures and provides tensile strength. No? Just a short review of the anatomy. Now, the aorta is a conduit from the left ventricle to the systemic circulation. The normal caliber or diameter, top to bottom, at the origin of the aorta in the ascending portion. It's approximately 3 centimeters in caliber or diameter. In the descending portion in the thorax, you have 2.5 centimeters. And in the abdomen, it's 1.8 to 2 centimeters. So note the normal tapering of the aorta, the distal portion. No? 3, 2.5, 1.8 to 2. All right, let's first discuss. I will not be discussing all diseases of the aorta. I'll be just confining my lecture on two of the most important diseases in the clinics that you have to know, no? Because it will may entail between life and death, no? Aortic aneurysm and aortic dissection. Let's start with aortic aneurysm. This is a pathologic dilatation or bulging of a segment of a blood vessel. When you say aneurysm, there's a dilatation of a blood vessel wall so that the resulting diameter is 50% greater than the normal or the original diameter adjacent to the diseased vessel. So this is the normal healthy aorta CT scan. And this is aorta with abdominal aneurysm. Okay, so this is the CT scan rendering. An aneurysm, aortic aneurysm, can dissect or rupture, and the force of blood pumping can split the layers of the artery wall, allowing blood to leak in between them. So there are several classifications of aneurysm. So we have fusiform aneurysm, which affects the entire circumference of a segment of the blood vessel, resulting in a diffusely dilated artery. In contrast, a saccular aneurysm involves only a portion of the circumference, resulting in an outpouching of the vessel wall. Between the two, a saccular aneurysm is more prone to rupture than the fusiform. No? Another classification is whether it's true aneurysm or pseudoaneurysm. When you say true aneurysm, it involves all three layers of the vessel wall, the intima, the media, and the adventitia. With pseudoaneurysm, all three layers are not involved and the risk of rupture is high. So let me repeat that. Between true aneurysm and pseudoaneurysm, risk of fracture is higher with pseudoaneurysm. And with fusiform and saccular aneurysm is more prone to rupture than fusiform aneurysm. So it's very important for us to know uh, the risk factors for the development of aneurysm. So this I'm talking about the degenerative type of aortic aneurysm. Because we also have congenital aneurysm or developmental aortic aneurysm. We have aneurysm secondary to trauma and aneurysm secondary to an infectious process. So all throughout the lecture, I'll be referring to the degenerative type of aneurysm. So risk factors for the degenerative type of aortic aneurysm are number one, cigarette smoking, hypertension, aging, hypercholesterolemia, and of course, atherosclerosis. So how How do they manifest? No, as I've mentioned earlier, depending on the location of the aneurysm, uh, we can actually predict the clinical manifestations or signs and symptoms of the patient because most thoracic aneurysms are asymptomatic. However, compression or erosion of adjacent tissue by the aneurysm may cause symptoms such as chest pain, especially if it involves the ascending the ascending portion of the aorta. Shortness of breath, cough, hoarseness, and dysphagia. I've already mentioned hoarseness. Uh, Aneurysmal dilatation of the ascending aorta may also cause congestive heart failure. This is as a consequence of aortic regurgitation and compression of the superior vena cava, which may produce congestion of the head, neck, and upper extremities, what you call SVC syndrome. An abdominal aortic aneurysm, just like thoracic aneurysm, commonly produces no symptoms. It usually is detected on routine examination as a palpable, pulsatile, expansile, and non-tender mass. Or it is an incidental finding observed on an abdominal imaging performed for other reasons. So, abdominal aortic aneurysms occur more frequently in males than in females, and the incidence increases with age. Cigarette smoking is a potent modifiable risk factor for AAA or abdominal aortic aneurysm. Abdominal aortic aneurysms more than or equal to 4.0 centimeters may affect 1 to 2% men aged more than 50 years old, no? And at least 90% of all abdominal aneurysms more than 4.0 centimeters are related to atherosclerosis. And most of these aneurysms are below the level of the renal arteries or what we call infrarenal abdominal aortic aneurysm. Abdominal pain may mean aneurysmal rupture and or dissection. Now, in TAA or thoracic aortic aneurysm, the risk of rupture is related to the size and presence of symptoms. The risk of rupture of TAA of less than 4 centimeters in diameter is 2 to 3% per year, going up to 7% once the diameter exceeds 6 centimeters. So this is an actual chest x-ray showing TAA. Picture A shows aneurysm involving the ascending and arch of the aorta. See the bulging there, no? While picture B shows an aneurysm that is in the descending thoracic aorta. Okay. This is an ultrasound of an abdominal aortic aneurysm. Picture A is the transverse section of a normal aorta. Look at the size, no? In contrast with picture B, this is a 5.9 centimeter abdominal aortic aneurysm with intraluminal thrombus. Huh? So, what are the complications of AAA? Of course, the most feared and fatal complication is rupture. Mortality rate of fractured AAA is up to 90%. Embolization is another complication because of the presence of thrombus, intraluminal thrombus, and because of atheroscler- atherosclerotic debris, they may embolize to the lower extremities, which may cut off the blood supply to that particular limb, producing acute limb ischemia. No? They say that the danger increases significantly after 5.5 centimeter diameter of an abdominal aortic aneurysm. So this is the annual risk of rupture of AAA based on the diameter of the aneurysm. Above 4 centimeters in diameter, note that risk of rupture correspondingly goes up. Less than 4, 0 risk of rupture. 4 to 5.5 to 5. And then up to 15% if it goes up to 5 to 6. So how do we diagnose this very important AAA? One is of course by ultrasound. No? This is readily available in almost all hospitals, and this is not that expensive. And the ultrasound is also used to monitor progression in size. That is the imaging test that we use when we want to see whether there is a rapid progression or none of the abdominal aortic aneurysm. CT scan is also used for the diagnosis, but again, I want to emphasize monitoring of progression. We use ultrasound, abdominal ultrasound. Now let's go to aortic dissection. This is a tear in the innermost layer of the aorta, allowing blood to force its way between the layers of intima, uh, tunica intima and tunica media, creating a false channel or false lumen. It weakens the artery wall, which can now lead to rupture or block in blood flow to vital organs. Okay. Patients will classically present with a tearing central chest pain radiating to the back. Just this is a CT scan using take note of the tear in the ascending aorta, which is the origin of the dissection. And then see the true lumen, the one which is brighter than the adjacent lumen, which is the false lumen. No? An aortic dissection is a they can be defined as acute dissection when diagnosed in less than 14 days, or chronic when diagnosed for more than 14 days. So aortic dissection is more common in men and in patients with connective tissue disorders like Marfan syndrome, and it has a peak onset at the 6th and 7th decade of life. Just to show you the pathophysiology of aortic dissection, note the intimal tear, no? Which is the start of the dissection, and from there, blood flows insinuates inside the tunica media. And this is the histopathology of a thoracic aortic dissection. demonstrating the separation of the tunica intima and tunica media. So remember that in aortic dissection, the separation is between the tunica intima and the tunica media. So let's go to the classification of aortic dissection. So we have Stanford and DeBakey, no? This is anatomic classification. Stanford classification divides aortic dissection into two groups, no? Stanford A and Stanford B. Stanford type A involves the ascending aorta and can propagate to the aortic arch and descending aorta. The tear can originate anywhere along this path, no? Type B, it does not involve the ascending aorta. That's very important, no? Type B does not involve the ascending aorta and can occur in any other part of the aortic arch and descending aorta. While the DeBakey classifies aortic dissection into type 1, type 2, and type 3. Type 1 originates in the ascending aorta and propagates at least to the aortic arch. They are typically seen in patients under 65 years and carry the highest mortality, quoted at 1% per hour in the acute setting. In type 2, this is confined to the ascending aorta. It's classically in elderly patients with atherosclerotic disease and hypertension. Now, type 3, it originates distal to the subclavian artery in the descending aorta. Further subdivided into 3A and which extends distally to the diaphragm, and 3B, which extends beyond the diaphragm into the abdominal aorta. Now, what are the clinical manifestations of aortic dissection? The characteristic presentation is that of a tearing chest pain that is so severe at its onset. No? This typically differentiates the chest pain of myocardial infarction, wherein there's gradual buildup of pain. No? But in aortic dissection, at the outset, it's already 10/10. No? That's what differentiates chest pain of myocardial infarction from chest pain of aortic dissection. And more often than not, the chest pain of aortic dissection radiates to the back. No? Yet the diagnosis is still challenging and they may present in a more subtle way. The most common clinical signs include tachycardia, hypotension, new onset aortic regurgitation murmur, or signs of end organ hypoperfusion. This is due to the false lumen and true lumen, no? With false lumen being more dominant. That's why there are end organ hypoperfusion, no? Exemplified by reduced urine output, paraplegia, lower limb ischemia, abdominal pain secondary to ischemia, mesenteric bowel ischemia, or deteriorating conscious level. No, these are all secondary to hypovolemia from blood loss into the dissection or cardiogenic from severe aortic regurgitation or pericardial tamponade. Now, how do we diagnose aortic dissection? Uh, so we have a 2D echocardiogram wherein we have the diagnostic intimal flap. This is a mobile, a linear density which corresponds to the dissection. No? CT scan, as I mentioned earlier, will also give you a diagnosis of aortic dissection, and of course, MRI. They all yield a high sensitivity and specificity for the diagnosis of aortic dissection. Okay, let's now go to peripheral vascular diseases. Uh, I'll be discussing deep vein thrombosis and venous insufficiency, peripheral artery disease, and lymphedema. Okay, let's proceed first with PAD, or peripheral artery disease. Okay, the most common cause of peripheral artery disease, or PAD, is atherosclerosis. And we all know that atherosclerosis is a systemic disease affecting all vascular beds in the body: cardiovascular bed, cerebrovascular bed, peripheral vascular bed. In cerebrovascular circulation, it may cause stroke, or TIA. In cardiovascular bed, it can lead to acute coronary syndrome. And in the lower extremities, it can lead to peripheral arterial disease. Nowadays, the presence of peripheral artery disease is considered a surrogate marker for cardiovascular and cerebrovascular disease. What's happening in the legs may also be happening in the heart and in the brain. Uh, in this lecture, I just want to point out that when I say peripheral artery disease, I am referring to the lower extremity arterial disease. Let's now go to the symptomatology of PAD. In more than half of patients, 53% of patients with PAD, they are asymptomatic. They have risk factors for atherosclerosis, they have risk factors for PAD, but they do not manifest any symptom. So that's the most common presentation of PAD. 53% asymptomatic. Now, in 35% of cases, the presentation of PAD is intermittent claudication. Intermittent claudication is defined as calf pain on walking, relieved by rest. Okay. In 9% of cases, patient manifests with gangrene, non-healing wound, and leg pain even at rest, what we call critical limb ischemia. Huh? And then in 3% of cases, acute limb ischemia sets in, often due to embolization. Now, what are the key components of the vascular physical examination? This is very important in the and is considered a cornerstone in the diagnosis of PAD. A comprehensive vascular examination, meaning to say, you get the blood pressure bilaterally, do a cardiac exam, palpation of the abdomen for aneurysmal disease, auscultation for bruits, and examination of legs and feet. And you have to examine the peripheral pulses uh, with the following scale: 0 if you cannot palpate for any pulse or absent, 1 if the pulse is diminished, 2 if it's normal, and 3 if the pulse is bounding, most probably due to AI or aortic regurgitation. On physical examination, be observant also of the telltale signs of the presence of risk factors for atherosclerosis that will put patients at risk for PAD, such as santelasma, no? Which may be due to hypercholesterolemia. and nicotine staining of the fingers for those who are chronic smokers. For palpation of peripheral pulses, it's very important that we assess the symmetry or inequality of pulses left and right, the presence of bruits, as I mentioned earlier, which may connote narrowing or stenosis of a particular vessel. Now, palpation of peripheral pulses involves the carotid, the temporal artery, the carotid, brachial, popliteal, posterior tibial artery just behind the middle malleolus, femoral, and dorsalis pedis. Just want to illustrate where they are usually palpated. I usually ask that in my preceptorial group. So what are the nutritive signs of ischemia? Meaning to say, if there is less or inadequate flow of blood to that particular uh, segment, what will you observe? So you have atrophy of the skin, or you can have thickened nails, hair loss, and of course cyanotic toes. These are the outcomes of absent or diminished flow of blood to that particular bend. And so, when we talk about PAD, we talk about ABI, or ankle brachial index. The ankle brachial index, or ABI, is the screening test for the presence of PAD using handheld Doppler, the systolic pressure of the ankle using either the dorsalis pedis artery or the posterior tibial artery, whichever is higher, is divided by the systolic pressure of the brachial artery. Huh? The ABI is 95% sensitive and 99% specific for PAD. Both ankle and arm pressures are taken using a handheld Doppler device. So how do you interpret an ABI? An ABI less than 0.9 is abnormal. So we have mild PAD if the ABI is 0.8 to 0.89. Moderate if it's 0.5 to 0.79. And severe, this involves your critical limb ischemia if it's less than 0.5. No? Now, what are the different, aside from ABI, how do we diagnose PAD? So we have segmental pressure and waveform study. This is localization as to the exact site of stenosis along the lower extremity. The beefy cuffs are placed across 4 segments in the lower extremity as you see here in the picture. One in the upper thigh, one above the knee, one below the knee, and above the ankle area. So you get the systolic pressures from each of these segments and a 20 millimeter mercury systolic drop in systolic pressure across segments points to the area of stenosis. For example, the pressure in the upper thigh is 100 millimeters mercury. And then above the knee, it dropped down to around 60. So you have stenosis uh, in the above the knee. That's more than 20 millimeters mercury. Another diagnostic test that you can use, imaging test, is the arterial duplex scan. It's actually an ultrasound. But it has a Doppler component, meaning to say you can measure the velocity of blood flow in that particular segment. And by measuring that, you get the peak systolic velocity. We can actually tell whether that stenosis is significant or not. We have that in our hospital. And there will be times when the ABI is normal, especially among the elderly, those with hypertension and diabetes. In instances like when the ABI is normal, yet the suspicion for the presence of PAD is high, a treadmill exercise test is warranted. The ABI may be normal at rest, but once the peripheral vascular circulation is challenged, by making the patient walk on the treadmill, subclinical PAD may be unmasked. No? And in the diagnosis of PAD, angiogram is still considered the gold standard. No? Not the ABI, not the treadmill, not the segmental pressure, not even the arterial duplex scan. The gold standard is still angiography. In angiography, a contrast dye is injected, and that dye will correspond to the flow of blood. So it can actually quantify whether the stenosis is significant or not. So what are the treatment goals for PAD? So once a patient is diagnosed with PAD, the goals of treatment are number one, you want to improve the functional status. For example, when we want the patient to walk for a longer period of time before he would experience cuff pain or his non-healing wound. We want his non-healing wound to heal so as to avoid amputation. We want to address all the risk factors for atherosclerosis, which are also same risk factors for cardiovascular and cerebrovascular event. So in order to decrease cardiac morbidity and mortality. So modification of risk factors is very important in the management of patients with PAD. Smoking is a significant factor for progression of PAD. For patients with PAD, the LDL or the bad cholesterol should be lowered down to less than 100 milligrams per DL, and the triglycerides to less than 150 milligrams per DL. For hemoglobin A1C, it should be less than 7% with postprandial glucose below 180 milligrams per deciliter and a fasting blood sugar of 80 to 120 milligrams per deciliter. Now, antiplatelets are indicated also for patients with atherothrombosis, since it can lead to ischemic stroke, myocardial infarction, and PAD. So when do you refer a patient to a vascular surgeon? Usually, a patient with intermittent claudication responds to medical management alone, such as supervised walking exercise and silostazole. But in patients with critical limb ischemia, meaning to say there's rest pain, there's gangrene and ulcer or non-healing wound, these are the subsets of patients that will need revascularization. Seldom will they respond to just medical management. So you need to increase the blood flow to that non-healing wound. No? So these are the therapeutic options for PAD. These are the different revascularization modalities in order to improve or increase the flow of blood to the lower extremities to promote wound healing and decrease the risk of amputation. So we have thrombolysis. Because it can lyse the blood clot, which occludes the flow of blood. No? Angioplasty with or without stent placement, and bypass of the occluded vessel, bypass of the lower extremity. And when all of these revascularization modalities fail, amputation is the last resort, especially for those patients with the infected non-healing wound or ulcer that can cause sepsis if you will not remove the source of infection. So let's now go to deep vein thrombosis. Deep vein thrombosis, as we all know, occurs due to the interplay of three factors: stasis, changes in the soluble and form elements of the blood, and abnormalities of the vessel wall or endothelial dysfunction. No? And this is what we call the varicose triad. No, we want to know the risk factors for deep vein thrombosis that contributes to stasis, abnormalities of the blood vessel wall, and changes in the soluble and form elements of the blood. Risk of thromboembolism is higher with more risk factors involved. So we have advanced age, immobilization, prolonged immobilization, previous history of thromboembolism, malignancy, surgery because it can damage the tissues, no? Trauma, primary hypercoagulable state, pregnancy, and use of OCPs or oral contraceptive pills. With prolonged immobilization, there's inactivity of the calf muscle pump, which exacerbates stasis in the soleal veins and behind the valve cusps. They say that during the first 3 days of confinement, prevalence of DVT is increased more so after 2 weeks of continued bed rest or immobilization. That's why the rule now is if a patient is hospitalized, usually as soon as possible we want them to walk. Or we place TED or thromboembolic stocking. No? Malignancy. The malignancy may lead to DVT. That's why one of the clues, if a patient has DVT, it is not a diagnosis actually. It is a clue that there's something going on. And one of the important diseases that you have to rule out in a patient with DVT is malignancy. This is what we call unprovoked DVT. No? There are thrombogenic factors that are elevated with cancer and therefore makes one prone to develop DVT. These are fibrinogen or fibrin degradation products, reduced levels of coagulation inhibitors like antithrombin, protein C, and protein S, which are the naturally occurring anticoagulant in the body. Now, with primary hypercoagulable states, these are inherited deficiencies of antithrombin 2, protein C, and protein S, and hyperhomocystinemia. All of these represent discrete genetic mutations that lead to a hypercoagulable state. One of the clues that you're dealing with a hypercoagulable state like APAS or antiphospholipid antibody syndrome is when a woman of childbearing age has three consecutive abortions. No, you have to work that patient for APAS or primary hypercoagulable state. Oral contraceptives and hormonal therapy. The use of OCPs and hormonal therapy may alter the coagulation system, like decrease in plasminogen activator inhibitor 1 and increase blood viscosity, platelet adhesion and aggregation, increase in fibrinogen, and increase in plasma levels of factors 7 and 10. Pregnancy. Pregnancy by itself is a pre-thrombotic state, and combined with impaired venous outflow due to compression of the iliac veins by the gravid uterus. During pregnancy, there is increased levels of fibrinogen, factors 2, 7, 8, and 10, decrease in protein S levels, and decrease in fibrinolytic activity during pregnancy. So how do you diagnose DVT? Currently, the mainstay is in the diagnosis of DVT is with high sensitivity specificity venous duplex scan. No, usually the venous duplex scan can detect the presence of DVT in the iliac, iliofemoral, and the popliteal vessels. So it has a sensitivity and specificity of more than 90%, which approaches 100% in some series. But intra-abdominal veins, like the inferior vena cava and the pelvic veins, they are blind spots of the venous duplex scan. So what do we do in this case? We have the MR venography or MRI. This is MRI is very sensitive in the diagnosis of proximal venous thrombosis, meaning the thrombosis in the pelvic veins or in the inferior vena cava. So why are we interested in DVT? This is because one of the fatal complications of DVT is pulmonary embolism. This is the most significant complication of DVT, and in 90% of cases, the source of the thrombus is in the deep veins of the lower extremities. That's why when you're entertaining pulmonary embolism, one of the tests that you have to request for is the venous duplex scan. Huh? So once the venous duplex scan is positive for deep vein thrombosis, we usually treat the patient as if the patient has pulmonary embolism. Huh? Majority of pulmonary emboli are clinically silent. If symptomatic with pulmonary embolism, massive pulmonary embolism, that occurs within 1 hour of presentation in 11% of cases. Another complication of DVT is what we call post-thrombotic syndrome. This is venous insufficiency after an episode of DVT. Organized thrombus usually damages the valves, making them less compliant to close, producing non-coaptation of the vein valves, producing backflow of blood to the lower extremities, which later on may lead to leg edema, hyperpigmentation, brown discoloration of the skin, and may lead to ulceration. So these are the goals of treatment for deep vein thrombosis. We want to prevent its fatal complication, which is pulmonary embolism. We want to prevent progression or extension of the thrombus and limit the development of post-thrombotic syndrome. So treatment for DVT, we go back to the three abnormalities that define DVT. For blood stasis, we use compression bandage or stocking or intermittent pneumatic compression device or IPC. To address the changes in the form and soluble elements of the blood, we give anticoagulants. We now go to venous insufficiency. So you see the enlarged and tortuous veins, superficial veins, no, of the greater saphenous and the lesser saphenous veins. And to your right are the deep and the superficial veins of the lower extremity. So you have distal external iliac vein, the common femoral vein, superficial and deep femoral vein, popliteal vein, posterior tibial vein, while we have two superficial veins. We have the greater and the lesser saphenous vein. CVI or chronic venous insufficiency happens when your leg, when the leg veins become damaged and can work as they should. Normally, the veins in the valves keep blood flowing up to the heart. This is an actual ultrasound view of the valves of the vein. Note that if there's no coaptation of the vein valves, chances are blood that should go up to the heart will now go back to the lower extremity. And with pooling of blood in the lower extremity, you have intravascular increase in intravascular hydrostatic pressure. And then there will be extravasation of that in the interstitial space, producing pedal edema. Okay? So what are the risk factors for venous insufficiency? So we have some people have a genetic predisposition to CVI, especially when there is an inherent weakness in the walls of the vein. So sometimes, usually we see them in the elderly, middle age, but we seldom see them in the 20s, no? But if we do, usually the mom has also venous insufficiency, meaning to say there's an inherent weakness in the walls of the vein that runs in the family. Sometimes we have congenital venous insufficiency. This congenital diseases cause malformations in the veins of the leg that one is born with. For example, some people are born without valves in their leg veins. No, obesity and pregnancy, uh, changes to the leg veins that prevent them from working as they should. For example, when the vein may get too wide, preventing its valves from closing all the way. No? or wearing tight undergarments, and sedentary lifestyle. Secondary causes are other medical issues that damage the leg veins, like previous history of DVT, producing scarring of the tissue that damages the valve, now producing post-thrombotic syndrome. And once you have severity of chronic venous insufficiency, we have stage 1 with the characterized by appearance of ankle swelling, mild discomfort, and venous dilatation, such as what you see here, no? This are telangiectasia. So all you have to do is elevate the legs above the heart and use compression bandage or elastic bandage or compression stockings. Now with compression therapy, either stocking or elastic bandage, this improves deep venous blood flow, facilitates resorption of edema, and helps support sagging veins. Sclerotherapy is another mode of therapy for telangiectasia. We inject sclerosant, no? Usually alcohol, just to cause irritation of the vein walls. With irritation of the vein walls, there will be closure of the vein walls. So you have no more telangiectasia. Stage 2, this is characterized by moderate edema or swelling, pronounced hyperpigmentation, brawny edema. Sometimes we have subcutaneous fibrosis, and of course, more pronounced varicosities. The recommended treatment is just increase elevation and compression. And the most severe expression of CVI is stage 3 CVI. Here we have severe swelling, and this is a hallmark of stage 3 is the presence of ulceration, which fails to improve in 4 weeks or heal in 8 weeks. Calf pain with may have or may do not calf muscles may do not they claudication. No? In stage 3, this is a multidisciplinary team composed of a plastic reconstructive surgeon, wound care specialist, and specialist in or infection control. No? So let's go to the last topic, which is lymphedema. Lymphedema is an abnormal swelling of the limb due to the collection of excessive amount of high protein rich fluid, no? Secondary to the defective lymphatic drainage in the presence of normal capillary filtration. This is a very disabling condition. I just want to show you here the location of the lymphatic system. No? Just a few words on the formation and movement of lymph. So on your right, we have the lymphangion. We have the one-way valve, no? Because of the overlapping epithelial cells, valve closed, backflow of lymph is prevented. Valve open, lymph flows inward. Fluid moves from blood capillaries into tissues and from tissues into lymphatic capillaries to form lymph. The overlap of epithelial cells of the lymphatic capillary allows fluid to enter easily but prevents it from moving back into the tissue. The valves located farther along in lymphatic vessels also ensure one-way flow of lymph. Now, just want to show you the basic pathophysiology of lymphedema, which is an imbalance between lymph absorption and production. There's an increase in production of lymph, but there is decrease in absorption. Lymph is primarily protein-rich fluid, and when this accumulates in the interstitial space, the tissue oncotic pressure increases with subsequent accumulation of water. No? So with protein-rich fluid in the interstitial space, secondary inflammatory and immune response set in with infiltration of mononuclear cells, fibroblasts, and adipocytes. So over time, there will be subsequent deposition of collagen and adipose in the skin and subcutaneous area, leading to progressive subcutaneous fibrosis that may look like this. So what are the classifications of lymphedema? So we have primary and secondary lymphedema. Lymphedema is classified as primary. This is usually congenital, sometimes with complete absence of the lymphatics, while in some, the lymphatic system is hypoplastic. In secondary lymphedema, this may be secondary to an infection like filariasis, no? Especially in Africa. So we have causative agent Wucherera bancrofti, Brugia malai, and Brugia timor, and other third world tropical countries. Or secondary lymphedema may be due to excision of lymph nodes, especially in the axillary area for radical mastectomy, metastasis to the lymph nodes, among others. No? So these pictures are example of primary lymphedema. To your left is an example of hereditary lymphedema in a baby. We have Milroy's disease. This occurs anywhere from birth to 1 year, twice as likely in females, and is 10 to 25% of cases. Lymphedema precox or mixed disease is obvious from birth to 35 years, often appearing during puberty. This is 4 times likely in females and is 65 to 80% of cases. Lymphedema tarda occurs later in life for those 35 and older, and is the rarest form, accounting for 10% of cases. For secondary lymphedema, so we have what we call elephantiasis or filariasis, secondary to infection. This is severe lymphedema. Post-mastectomy lymphedema, often after removal of axillary lymph nodes. Okay, so I have here a table for stages of lymphedema. We have here characteristic features for each stage. Asymmetry of limbs may be seen already with stage 1 lymphedema, with marked fibrosis and full-blown limb asymmetry seen in stage 3 lymphedema. So in stage 3, you have marked trophic changes in the skin, while in stage 1, there's no visible change in skin. But there's early protein-rich fluid accumulation already. Okay. So due to the lateral enlargement of the upper or lower extremity, one can expect that the patient may have the following signs and symptoms: feeling of heaviness, warmth, tightness, or reduced flexibility of joints. Of course, this is obvious. Asymmetrical appearance of extremities and tightness of jewelry or clothing. So how do we diagnose lymphedema? MRI has played an increasingly important role in the diagnosis and evaluation of lymphedema, as it provides high spatial resolution of the distribution and severity of soft tissue edema, which characterizes diseased lymphatic channels. Now, lymphoscintigraphy is the recommended uh, imaging modality before, no? Uh, this is picture A. This is the a normal lymphoscintigram. Uh, See here the usually this is injected the injected sites at the feet, no? And lymphatic vessels you see draining the injection sites can be seen as well as the lymph nodes in the groin. Yung black na nagmanifest, no? These are lymph nodes that the vessels lead to. Compared with the picture B, there's lymphatic failure in this patient. There's a lack of uptake in the groin and absence of lymphatic vessels, just like as opposed to a normal lymphoscintigram in picture A. And so, how do we manage lymphedema? The mainstay really is what we call CDT, or complete decongestive therapy. Complete decongestive therapy is composed of manual lymphatic drainage, compression bandaging, exercises, and skincare. The difference between manual lymphatic drainage and usual massage therapy is that this is very light since the lymphatics are very superficially located. No, once you a deep massage is a no-no in a patient with lymphedema, and there's a school that teaches how to do CDT and MLD. These are the goals of the of manual lymphatic drainage or MLD. It increases peristalsis of lymphangion and breakdown of fibrotic tissues, which in turn will now increase the flow of lymph in the lymph vessels, decreasing congestion in the interstitium. Now, medical compression bandaging. The compression that is being used in lymphedema is multi-layered, no? Composed of layers of bandages which prevent refill of lymphatics by providing low stretch when there is no muscle contraction and higher compression when muscles contract. No? Therapeutic exercise. These are also taught to patients with lymphedema in a hospital with a fully developed center for lymphedema. No? Exercise facilitates muscle pumping, which progresses proximally to distally. It is composed of very low resistance, few repetitions with rest as needed. So you have dumbbells, and then we have sleeves. No, if the lymphedema is in the upper extremity, we have sleeves or stockings that can usually be fitted for that particular limb. And during therapeutic exercise, the compression bandage or sleeves should be worn. Usually, persons with lymphedema of the upper extremity, they usually wear long sleeves. Since the edema is protein rich, uh, they can be easily they can easily develop lymphangitis or inflammation of the skin. Once you scratch the skin of the involved arm, usually it gets infected, no? Because bacteria located just on the surface of the skin will now have an entry into the bloodstream because of that scratch, and you have lymphangitis. I think that's the last slide. Any question? How many sections are you? Because I'll be giving this lecture to the presidents of the class. Just go to the hospital. Just go to my clinic. I'll give you this whole lecture. And my exam questions, uh, I'll get the exam questions from this lecture and not from any other books. So if you just listen, you will get the correct answers. Questions? Questions, ladies and gentlemen? Lana?
Doc,
Yeah?
good afternoon po.
Sure.
Um, um, sa chronic venous insufficiency po kasi na part kanina
Um,
for stage 2, I noticed na sabi niyo po na yung treatment is just increase elevation and compression. I'd just like to ask if pwede ba i-treat yung stage 2 na CVI with sclerotherapy.
you know what? The sclerotherapy, the that uses sclerosant, no? And sometimes hypertonic uh, sodium chloride. These are usually not intended for CBI with veins that are large. Yung affected veins niya, severe ang tortuosity, malalaki na. Especially for those patients who are hypertensive. Mas madaling mag-close, mag-cause ng irritation and then closure if that's only telangiectasia. If it's already varicose veins, sometimes they do not use sclerotherapy, but there are other modalities like endovascular, no? Or uh, laser. Other modalities other than sclerotherapy. These are primarily indicated for small, small or mga venules pa yan. Telangiectasia nga. When I say increased compression and because there are several gradation of pressures when you treat CVI. For mild CVI, 10 to 20 millimeters mercury will suffice. No, the pressure of the stocking. This is what we call graduated compression stocking. The highest pressure is in the ankle area. Then as you go up, the pressure diminishes. For patients with moderate CVI, usually use 20 to 30. But that's already, some patients may already complain of pain. That's how tight the stocking will be, around 30 millimeters mercury pressure. That's what I mean by increasing compression. Okay, good. What else? Good
Hi po,
question.
Doc. Yes po.
Yes.
Hi po, Doc. In terms of the claudication in pad po, how do we make sure that it is caused by pad and not just a simple muscle pain po, especially in the elderly po? Thank you po.
Yes, a very good question, no? In claudication, uh, the cause is vascular, no? Blood supply to the limb. So that's why when you walk certain distance, it will be more painful. So what do you do? You have to rest. So once you rest, because the amount of work that the calf muscle uh is lesser, no? So that's why the pain goes away. And when you walk again, the pain will again come back, no? But in a patient who has pseudoclaudication, meaning to say the pain is not secondary to a blood supply or a vascular in etiology, you have what we call pseudoclaudication. Meaning to say, when the patient is at rest, there is pain. But when he walks, the pain goes away. So that's one of your clues that the pain is not vascular in nature. The claudication is not vascular in nature. More often than not, it's a problem with the spine, no? Uh, Parang may slight spinal stenosis. The nerves going out of that spine has a problem. The problem is with the nerve, not with the blood vessel, with pseudoclaudication. So one of the tests by which you have to check out is get an ABI. ABI is for vascular, no? Just X-ray of the lumbosacral. You may see problems with the spine, no? Degenerative. Good. I did not I did not discuss the different causes of claudication. But what I emphasized was the vascular claudication. No? So baliktad, if it's secondary to a nerve problem, uh, in contrast with the vascular type of claudication. So the nerve type is pseudoclaudication. The vascular type is true intermittent claudication. What else? I like your questions, huh? Lana, no more questions? Clarifications? Okay, just inform your president to get the this lecture here in the hospital. Okay? Shall we say goodbye? Thank you for your attention. Okay.
Thank you,
That's,
Doc.
okay.
Bye, Doc.